For those of you that don't know, my name's Doron Sher. I'm an orthopedic surgeon, and my particular interests are in knee and shoulder surgery. I consult from the Randwick and Concord offices of Orthosports, and I have a public appointment at Concord Hospital. I'm sure there's people in the audience wondering how a talk on nutrition fits in with a day of orthopedic and sports medicine talks. Well, as a physiotherapist, as Andreas just mentioned, you're in a unique position to positively influence patients both before and after any surgery they have. And so the two things I want to focus on today are firstly, how nutrition can avoid complications after an operation, and secondly, how nutrition optimizes recovery. So I do a combination of sports surgery, joint replacements, and trauma work, and I have a very wide age range of patients, from young athletes to elderly and frail patients. So my involvement with dietary intervention to help patients actually started many years ago when I was trying to help my overweight knee replacement patients lose weight to avoid or delay surgery. While the initial focus was on weight loss, we soon came to understand that changing what people ate could optimize recovery after surgery. Now, as a surgeon, people come to see me when they're in pain or they've injured themselves. My goal is to return these people to an optimal level of function. Many times this involves surgery, and unfortunately, even with modern drugs, cutting people open hurts them. This can restrict their ability to get going, even if we encourage them to do so. And there's obviously times when we need to immobilize the limb, which clearly leads to muscle wasting. So there are three things that are critical to a patient achieving an excellent outcome. The first is that they don't get a complication like infection. The second is for them to heal the deep tissues and the wound once it's closed. And the third is to rehabilitate the limb properly and restore muscle bulk, which is basically where you guys come into it. All three of these are directly affected by what they eat. So I'm sorry to start with such a gory slide, and I'm sure many of you have seen a knee replacement before, but this is a typical case example because this is becoming one of the most commonly performed orthopedic operations. There's clearly a lot of soft tissue trauma during the surgery. But remember that the principles that we're discussing today apply to all surgical procedures and also patients recovering from non-surgical trauma and anybody with a chronic inflammatory condition. So once we finish our knee replacement, the wound on the knee looks like this. And we need to prevent this beautiful, neat wound from turning into this. In a nutshell, how to reduce the chance of a surgical complication. The problem is that as many tricks as I use as a surgeon, it's ultimately the patient factors that determine the final outcome. So let's talk about how nutrition is important for these patients. So I'd like to thank Dr. Choi for the National Institute of Health for sharing this data. He looked at 50 to 70-year-old hospital inpatients. These patients had continuous glucose monitors placed on them to monitor their blood sugar levels in real time. The graphs that you see here are on non-diabetic patients, otherwise well-healthy patients. So I repeat, they were not diabetic patients being monitored, and they were on a standard hospital diet for 7 days. The grey bar is where we'd like their blood sugar to be. And I'd like you to note not just the time out of range in yellow and red, but the significant variability in the levels, even when they are in the 8 to 4 normal range. They certainly don't have tight blood sugar control. So let's look at the carbohydrate content of foods routinely served in hospital and keep these in mind for later in the talk. I'm going to leave this up here just for a little bit so you can read through the slide and think about what a typical breakfast in hospital looks like in terms of sugar ingestion. It's a bit scary, really. So now let's go back to the blood sugar tracings for the same patients still in hospital for the next 7 days. The only change in their treatment was to reduce the amount of dietary carbohydrates given to them. This was without calorie restriction. You can see that it takes less than a day for the blood sugar levels to drop back to a normal range with a virtually flat line in their levels. So why would I be interested in this as a surgeon? The problem is poor blood glucose control significantly impacts on surgical outcomes. It causes higher rates of infection, heart attack, kidney failure, reoperation, and ultimately death. And this applies to every type of surgery, not just orthopedics. There have been quite literally hundreds of studies on this topic. Basically, if we want patients to do well following surgery, we would be well advised to control their blood glucose levels. And it's not just diabetics who have poor blood glucose control, as you saw in those previous slides. This large study showed up to 46% of all hospital inpatients experience high blood glucose levels. So when you think about the graphs we saw on the non-diabetic patients, how much do you think it's going to be worse for a diabetic or someone with insulin resistance? Which unfortunately in these days of obesity in our population is leading towards 60% of the population. All the data indicates that inpatient hyperglycemia or raised blood sugar levels is associated with an increased risk of complication and mortality. And these bottom three studies range from 2002 all the way through to 2020 and show the same outcome. So I won't keep harping on about it, but there is heaps of data out there, and if you'd like to get it from me, I'm very happy to provide it. Now, putting complications to one side, what about healing? We need the skin, which is made of protein, to heal, and then the muscles to build up to get them going. So an operation of this size provides a major stress to the body: fasting, trauma of surgery, pain medication, after which the patient, who's often frail to begin with, needs to mobilize protein in the form of amino acids to begin the healing process. So fasting and surgery causes a stress-induced catabolic state and insulin resistance. And if you give them carbohydrates, this just adds fuel to the fire. So the question is, what nutritional strategies have the best evidence basis to help? Well, let's go back to basics. As you all know, skeletal muscles are the muscles used to move the bones and joints. The tissue has a unique ability to alter its metabolism and the size of the myofibers in response to changes in mechanical loading. And that's what you guys do pretty much all day, every day. Chronic mechanical loading leads to an increase in skeletal muscle mass and an enlargement of muscle fibers, while prolonged mechanical unloading results in a significant decrease in muscle mass and cross-sectional area. So you see in the image on the left the effects of positive mechanical loading. To the right, you see the after effects of mechanical unloading, causing significant thigh muscle wasting. Now, we know that muscles experience atrophy or wasting during unloading, and these muscles are more susceptible to injury when they're reloaded or reweighted. This has very important implications when I'm trying to get a patient back to work or sport. So let's take a little bit of a dive into protein and skeletal muscle and come back to how it affects what I do with my patients. If you look at a muscle under a microscope, you'll see these stripes or striations, as you see on the screen. The pattern's formed by a series of basic units called sarcomeres that are arranged in a stacked pattern throughout the muscle tissue. These are repeated throughout the muscle, and there are thousands of sarcomeres in each muscle cell. Now, muscle is a specialized tissue which can change its length, that is, contract or shorten and lengthen. And it's the change in the length of the proteins that causes the muscle to contract. So from a microscopic level to a muscle that we can see, the muscle is a whole organ. So muscle fibers, blood vessels, nerves, and connective tissue. This is important because the muscle isn't just protein. In fact, only about 20% of the muscle is made up of protein, and it's important to distinguish between how much protein we need to eat versus how much of a piece of chicken, fish, or steak we might need to eat to get that protein amount. Now, intuitively, everyone knows that muscle is made up of protein, but we also understand that protein is important to us as part of our diet. But what actually is protein? I think we all know that carbohydrates are made up of glucose. When you link 12 or more glucose, you get a complex carbohydrate. But interestingly, not many people can tell you that the basic building block of a protein is an amino acid. It's often represented as these squiggly diagrams with fat and skinny sections and lots of different colors. Just like joining many glucose together forms a complex carbohydrate, joining many amino acids together eventually forms a protein. And the reason these are called amino acids is because of the H2N side chain that you see on the left-hand side of the image. If you join two amino acids together, it forms a peptide. A polypeptide in the body is usually about 300 to 1,000 amino acids, and that's what's known as a protein. It's how they're folded that gives them their special biological activity. And while these are very diverse and found all over the body with lots of different shapes and functions, I'm just going to talk about skeletal muscle. Now, I think most of us would have heard of an essential amino acid. Well, all amino acids are actually essential for normal functioning of the body, but only some amino acids can be manufactured in the human body. The only way to get others is to eat them. So unlike ruminant animals, which can produce all of their own amino acids, we have to eat some by eating protein from another source. The one that I want you to particularly notice is leucine in the top left-hand corner, which is one of the essential amino acids. Now, amino acids actually have a wide array of functions, but today we're going to stick to protein synthesis. Remember that a major source of amino acids is simply reusing the stuff that's already in the body. So the maintenance of skeletal muscle mass is dependent on the balance between the rates of muscle protein synthesis and protein degradation. Now, when a protein's been around for a while, it gets a bit old and gets damaged. And this is particularly the case when the blood sugar is high and they formed advanced glycation end products, or AGEs. And then the body triggers the recycling process. So this graph shows a breakdown of the various components of a steak with a nutritional analysis. The protein is about 20 grams per 100 grams, which is what we expect. And 20 grams of protein is not a 20-gram steak. It's about a 100-gram steak or fish or piece of chicken. In terms of nutrition, protein is an absolute requirement, but ingesting carbohydrates separately is not. Number one, we're able to make our own carbohydrates. And secondly, if you look lower down, even within the steak, there's about 12 grams of carbohydrate per 100 grams. And that's because it's a whole organ, not just pure protein. So coming back to muscle building, we also know that for most animal proteins, you need to consume about 30 grams of protein to get 3 grams of leucine, because leucine is about 8% of most animal proteins. This is important for later. So the next logical question is, how much protein do we need to get the amino acids we need to survive? Don Layman is an expert on this, and he emphasizes the point that recommended dietary intake is the minimum intake required to keep you healthy, not the optimal amount. If you're on a diet which restricts calories and protein intake, your body will start to lose lean body mass and muscle. The only way to maintain muscle mass is with adequate levels of protein intake. The graph also shows you the very wide range of safe protein intake. As high as 200 grams of protein per day has been shown to be safe, and that equates to about 1 kilogram of steak, or fish, or chicken, which would be very hard to consume. The blue X is where most Australians are in terms of their protein intake, well below the safe level. So building muscle isn't a straightforward process. It requires the interactions of enzymes and hormones, and protein production is something that is not always happening at high levels in our bodies. As an adult, there also seems to be an on-off switch which only turns on when a critical amount of amino acids are present with a leucine trigger. Children are different. They have lots of hormones which drive their growth, and so their protein requirements for growth are not quite the same as adults. Now, we also know as adults we tend to develop insulin resistance as we get older. This applies across all of our tissues, and skeletal muscles is one of those tissues. So we need more insulin to drive muscle growth as we age. And this is why in adults the hormone drive is less than it is in children, and we need drivers like leucine or mTOR to be involved. So in order to grow and divide, cells need increased production of proteins and also suppress breakdown pathways. There's a product called mTORC1, which I'm not going to go into, which plays a central role in modulating these processes and controls that balance. Now, the main driver for mTOR is the amino acid leucine, one of the essential amino acids. The main sources of it are animal proteins, meat, fish, chicken, and dairy, but it is found in things like tofu and navy beans. Now, as I mentioned, for most proteins, you're going to need to consume about 30 grams of protein to get 3 grams of leucine, because leucine is 8% of animal proteins. The body requires a trigger to make muscle protein. It's not something that's happening without that on-off switch. In order for the trigger to be activated, you need to consume a minimum amount of leucine in a single meal, not separated out through the day, but in a single meal. This then triggers muscle synthesis, assuming you've got the rest of the amino acids. So if you consume less than 2 grams of leucine at a time, you will not get the metabolic response to build muscle. Having 3 grams is better than 2 grams, but 5 grams isn't any better than 3 or 2, so it's not a dose-response curve. You don't have to eat more once you've gotten to that trigger. So in a nutshell, if you eat protein at a meal which doesn't reach the leucine threshold, then what you've eaten can't be used to build muscle. The protein quality also makes a very big difference to this, and unfortunately, plant proteins are nowhere near as effective as promoting muscle building as animal proteins are. So let's go on to what the science tells us. Let's see how we're doing in the real world. We go to such efforts, pre-planning, antibiotics, sterility, dressing, and I walk out into the recovery room to see my patients being given frozen sugar in the form of an icy pole or a Zupa Duper. Nice and cool and refreshing, but they're not very helpful for keeping blood sugar stable. Now, I'm sure many of you have had operations yourself, and you know when you get into the second stage of recovery, what do you get given? Generally a white bread sandwich and a glass of juice. I'd like you to think back to that slide that I showed you about bread and juice and about how much sugar they are in them, and you think, what's that going to do to your blood sugar? Maybe 12 teaspoons of sugar if you're wondering. So I go see the patient the next morning on my ward round, and this is typically what I find next to them because they've been snacking on it overnight. Once more spiking their blood sugars and creating inflammation in their bodies. And unfortunately, you can buy Kit Kat and fruit juice from the vending machine in the day surgery unit. Breakfast the next day is just limitless carbs. Lunch is no different, which is ultimately sabotaging my surgical outcomes by way of poor blood sugar levels and inability to build muscle. So despite my best efforts, there's a huge area which is out of my control when looking after my patients. This is leading to poorer outcomes overall, but particularly in terms of wound infection and slower rehabilitation. I ask you though, are we really doing the best we can for our patients? And I put it to you that we are not. So how can we be part of the solution? Well, it's all about patient education. We know prehab works when it comes to joint replacement, and there's no reason that we shouldn't focus this and extend it to dietary preparation. And this is where you guys are in a unique position to spend time and talk to the patients. They need to understand that muscle building requires a combination of eating protein and exercising. They need to hit their leucine trigger, which means eating a minimum of 20 grams of protein, 100 grams of chicken, fish, meat, whatever it is, twice a day, ideally within about 2 hours of their exercise program, but it doesn't have to be. This really isn't difficult to achieve with only a small amount of pre-planning. Bumping up the protein for about 2 weeks before surgery and 6 weeks after surgery is probably all it takes to make a massive difference. But even doing it once or twice during their hospital stay will be better than not doing it at all. So when patients are admitted to hospital, they're given a food menu. But they don't have to choose all the sugar-containing options. If you choose the protein on the menu, just ask for a double or triple serve, which will not only make you feel full, the satiety, keep your blood sugar levels low, but also get you to the point of reaching your leucine threshold to start building muscle to aid your recovery. What about breakfast? Full-fat yogurt, cheese, bacon or salmon, and eggs is a great way to kickstart your day. Never be scared to get your family members to bring in the type of food that you like as well. Stay away from fruit juice and other carbohydrate or sugar-containing foods. Keeping the blood sugars in range and building more muscle will help me as a surgeon and you as a physiotherapist to provide an optimal outcome for the patient. Of course, this does need to continue once the patient gets home, but at least at home, they're in control of their foods. So I guess to sum up, my job as a surgeon doesn't stop once the wound's closed. You and I need to educate the patient to the dangers and the advantages of their food choices. Just because a patient is in hospital doesn't mean they should eat food which spikes their blood sugar. Once the bad stuff is removed, we need to replace it with adequate amounts of protein. Try to get the patient to eat their protein within about 2 hours of their exercise if possible, but there's no problem combining their protein with salad, green leafy vegetables, or other things. But it's better to stay away from the starchy options like corn and potatoes where possible. Together, we need to get the patient to heal, recover, and restore optimal function in the shortest time possible. This doesn't mean that they need to change their eating habits forever, and some people don't like to eat this way for the rest of their lives, and I'm not trying to push them to. But certainly for a few weeks before and after surgery, it makes a huge difference. The message needs to be, get rid of the carbs, and more importantly, make sure you're getting enough protein at any single meal to stimulate muscle production. I'm really looking forward to working with you guys to achieve this outcome for our patients. Thank you.